typically, after that, we may possibly aspirate it. But can you tell us a little bit more about the workup of that in that case, and then what lab markers you'll draw and what you're looking for in the lab values?
I think this is always this is a I feel like this target is always shifting, but there's some constants that I maintain as far as the gold standards of treatment and stuff. There are some other labs that people will draw more for academic and intellectual curiosity. But as far as testing purposes are concerned, I think the place to start is an ESR and CRP for sure. If you have a high clinical suspicion for infection, it is not unreasonable to aspirate right away. If someone's got a large effusion with erythema, fevers, and that reported history, because by the time you send them out for labs and they get their labs and the labs come back, I mean, you could be several days away from getting an answer. And then you have to aspirate. You're just delaying treatment. If you have a high clinical suspicion, I think aspiration at the time of the first visit is absolutely warranted. But ESR and CRP is sort of the gold standard. People can draw D-dimers. Some people will draw things like you can get like IL-6 and things like that. Those have not found their way as being that useful in my practice at this point. But the new sort of MSIS criteria by Parvizi in his group, that chart, sort of the weighted chart of different lab values and I think that's been very, very helpful. And I think that every surgeon who does joint replacement should have that chart, and I think every resident should have that chart cut out and pasted on their workstation wherever they are to evaluate that. But ESR and CRP are good lab markers. If either of them is elevated, I will aspirate. And then I send the fluid. You send the fluid for everything you said here. Yep. Synovial white blood cell count with differential. If someone has any concern that there might be some metal on metal wear in the knee, sort of they've worn all the way through their polyethylene and the implants, sometimes you see severe poly wear and the knee is almost dislocated, and that femoral component will be hitting metal tibia. In that case, anytime there could be a chance for metal on metal debris, you want to get a manual differential, and that's definitely a testable topic. You see that in the hip. If someone has a metal on metal hip, sometimes the cell count will be falsely elevated because the machine gets confused by the metal ions. You want a manual differential for that. And then you definitely don't want the patient to have been on any antibiotics recently that can affect your cultures primarily. You can still have an elevated cell count if someone's been on a few days of antibiotics, but in general, your cleanest aspiration is going to be off of antibiotics for at least 2 weeks to have good culture data, the cell counts. And I think more and more alpha defensin is becoming, I don't want to say gold standard, but it is becoming a very, very useful test for periprosthetic joint infection. It's not something that's needed every time. So one thing that I will do is just from a functional standpoint, that's a send out lab for us. So I will have my residents send cell count and culture and everything for our in-house labs. And if the cell count is in a gray area, like let's say, 1,300 white blood cells with 63% or 65% polys, I'll then go ahead and have them send the alpha defensin test in. But if I get the aspiration, they'll have everything put in the vials and everything and set up for alpha defensin. But if I get my cell count back and it's 40,000 white cells, I don't need alpha defensin for that. It's infected. So I think that's one thing that's been helpful. But you can see here the number is, so the greater than 1,154% neutrophils, that's sort of the lowest suggestive infection numbers. Doesn't mean that everybody above that had a very high rate infection, but below that was relatively predictive of not having an infection. That's what you're saying there. Yeah. So if you're below that threshold, it is pretty clear that you do not have a joint infection. If you are slightly above that threshold, it doesn't mean you have one. It just means that you need to kind of look at all of your data and add up all of those points on that MSIS scale and compare everything that you're looking at. And then within 3 weeks or 3 to 4 weeks, it's an acute, if you're trying to evaluate someone with an aspiration in the first 4 to 6 weeks after surgery, yes, that number is going to be higher. I've seen lots of numbers for that, but 10,000, over 10,000 for a knee and up to 30,000 times for a hip can be normal in the first 4 to 6 weeks after surgery. So, appearance of the fluid is actually not that predictive of infection. So you draw the fluid out, you can say, "Oh, this looks great," and then it's infected, or you say, "Oh, this looks like absolute pus," and then it's not infected. And so that's why the appearance of purulence on the MSIS criteria is not a major criteria for infection.
Okay.
I do not like CBCs. So when someone tells me someone's white count, unless they're septic in the ICU, their white blood cell count is not that helpful to me.
Yeah. Okay. And I think all those were really good topics to bring up that you mentioned. And just thinking, like, in the clinical setting at this point, we likely have a pretty decent idea of what's going on, or hopefully we have an idea of what's causing this pain.